Hello, and welcome to this debate regarding the use of restraints and seclusions in individuals with developmental disabilities. My name is Caitlin Dillard, and I will be the introducer for this debate. We have chosen to use an informal structure for this particular debate, and we will be discussing the pros and cons for using restraints and seclusions. We will begin the debate with Michaela, the pro summarizer, who will be supporting the use of restraints and seclusions and how they are in the best interest of the individual, how they keep the individuals from self-harm, and how they keep staff and others safe. Rachel-Mae Curtis will be illustrating the three main points during this time with visuals. And then secondly, we will hear from Casey Kramer, the researcher who will be discussing the current research that was found on the use of restraints and seclusions. Third, we will begin the con side of the debate, where we will hear from Abby Waterman. She will be discussing the use of least restrictive measures, and illustrations will be given by Rachel-Mae Curtis again. Fourth, Casey Kramer will be then discussing current research on least restrictive measures. And lastly, we will hear from the fielder, Rachel Marks, who will be given frequently asked questions and touch base on any other specific points. We are now ready to begin our debate.
Thank you, Caitlin. As stated previously, my name is Michaela, and I will be supporting the use of restraints. There are three main points that I will make on this topic. The first point I will cover supporting the use of restraints is that restraints are in the best interest of the individual. I first want to state that restraints should only be used when the crisis situation occurring cannot be managed with less intrusive means. According to MOSA, the use of restraints should be viewed as an extraordinary event and limited to recommended indications. Restraint requires a written order by the physician, and its use should immediately be discontinued when less restrictive alternatives are feasible. Restraints are only in the best interest of the individual when all other methods of behavior modification have been attempted and proven unsuccessful. It is also important to remember that all people should not be restrained in the same manner. According again to MOSA, the type of restraint or seclusion used should be determined by the characteristics of the patient and what his or her best interests are. Before a restraint procedure is implemented, staff should take an in-depth look at what they want to accomplish by using a restraint and also how to eventually fade out the use of restraints from the client's care plan. There are instances where restraints are necessary. However, they should not be used without thorough planning and guidelines being in place. MOSA also states that guidelines should be developed in every public psychiatric setting dealing with when to act, whether to administer restraints, and the duration of restraint. Legal and regulatory controls need to monitor the use or misuse of restraints. This must be tempered by the acknowledgement of the use for added resources that ensure adequate staffing and training in the appropriate use of these procedures to prevent violence. One of the most important things to remember, the autonomy of our clients should all be implementing a restraint. The basic dignity of patients who have been restrained should be protected, and they should be provided with regular personal hygiene, bathroom, exercise, nutritional, and fluid breaks. Patients who are restrained should be provided with a comfortable environment that supports and maintains human dignity. The second point I will cover is the use of restraints to protect from self-harm. Occasionally, the clients we work with will engage in severe self-injurious behavior, or SIB, or self-harm. In these instances, the primary goal should be safety of the client. According to Peterson, physical restraint is a widely used protective procedure, often implemented for a variety of reasons, including prevention of violence, self-injurious behavior, and injury. Restraint should not be used as a punishment for bad behavior, but should be used if the safety of the client is at risk because of self-harm. As stated previously, restraints being used for this purpose should always be the least restrictive possible and be faded out quickly. It is also important to consider that not all self-harm needs to or should be managed by the use of restraint. Modulation of force is a term used to describe using the least amount of force necessary to manage a client in a restraint. For example, let's say a client engages in two types of self-harm: head banging on hard surfaces with enough force to make a sound, and hand biting with minor force that does not break the skin. If the client is cleared for restraint to prevent self-harm, it would be unacceptable to put the student into a restraint to protect against hand-biting behavior when it could be managed with far less intrusive procedures. Restraint would only be used if the client engaged in head-banging behavior, as this is a much more severe instance and could cause extreme harm. The final point I would like to discuss is the use of restraints to protect staff and other students from violent behavior. As stated by Howard, staff in intellectual disability services can experience high levels of violence, which may lead to burnout. Staff burnout may result in poorer quality of services. Previous research has suggested that factors such as fear of violence, self-efficacy, and staff support moderate the impact of violence on burnout. Centers in which restraints can be used can give staff the ability to cope with violence as they have been trained to react to it. As stated before, there needs to be permission from physicians or parents before a restraint can be used, and it is important to use the least restrictive restraint possible to manage the situation. There will always be hair pulls, bites, punches, and many other forms of violence in our field, but modulation of force and staff training in restraint and protective procedures can be extremely important factors to decrease burnout. Howard also states that services which are organized to manage violence may be better placed to support staff experiencing violence. Fear of violence may decrease with exposure to violence, perhaps due to self-efficacy. Training and support for staff may increase self-efficacy, thus reducing burnout. Training staff to be responsive and to read warning signs when crisis situations arise is an extremely important tool for staff to be prepared when violence occurs. Restraints should be used if they are in the best interest of the client. This means exhausting all other options before moving into restraint and preserving the dignity of the client. Restraint should be used in the event of serious self-harm as a protective procedure if there is imminent danger to the client and the behavior cannot be managed with least restrictive means. Finally, the restraint training and the ability to implement restraints on extremely violent clients can decrease staff burnout and increase quality of care. Thank you. I will now pass the floor to Rachel Marks, who will be discussing current research on the use of restraint in seclusion.
Thank you. Michaela had touched on the pros of using restraints with clients who exhibited behavior that is harmful and or injurious to themselves or others. With the use of peer-reviewed articles, she was able to receive reliable information to support her side of this debate. The articles she had used included those written by Ruth Howard, Reese-L. Peterson, and M.Y.H. Musa. Each author had stated the positives of using restraints, as well as describing the effects of using restraints to have positive outcomes. As Musa had pointed out, it is much of restraints are associated with punishment, custodial care, institutional abuse, and neglect. Although in retrospect, the effect of a restraint is positive. With the use of restraints, the behavior of the client can be controlled and redirected to where the client is once again in a calm state. To address the positive of physical restraints within a school setting, Peterson had conducted a literature review. With this literature review included an overview of 5 studies related to physical restraint for those who are diagnosed with autism spectrum disorder, or ASD. Concluding this literature review, it was determined that there had been positive effects with the use of restraints in the schools. Also, it was noted that the student safety is taken into consideration when implementing these types of restraints. This includes much training is conducted before a restraint is put into action. I am now going to pass it over to Abby, where she is going to discuss the opposing side of this debate, that is the cons with the use of physical restraints.
Thank you, Casey. As Caitlin stated earlier, my name is Abby, and I will be discussing the negatives of the use of restrictive measures on individuals with disabilities. The first point I would like to address is how restraints are one of the most restrictive procedures to use with individuals with disabilities. The Association of Behavior Analysis International, otherwise known as ABAI, and its members firmly oppose the inappropriate or unnecessary use of seclusion, restraint, or other intrusive interventions. Many individuals with severe behavior problems can be treated without the use of seclusion, restraint, or other intrusive restrictive interventions. ABAI also notes that there are many instances where restraints are necessary but require meticulous clinical oversight and control. A physical restraint is performed on an individual to restrict the movement of the individual in an involuntary manner. A chemical restraint is administered to the individual, usually through a hypodermic needle, and restricts the freedom of movement of the individual and can even sedate them to the point where they lose consciousness. Seclusion is used to separate an individual from stimuli that may be exacerbating the individual's distress. While in seclusion, there is to be no interaction with the individual, and they remain by themselves for extended periods of time until they calm. In 1990, Milstein and Cotton conducted a study of 102 children in a psychiatric treatment setting. They found that seclusion was most often used when the facility was at its busiest. They also found that the time the individual spent in seclusion often increased with each occurrence, regardless of the child's behavior. The second point I would like to address is the lack of policies in place to regulate the use of restraints in the United States. In 1999, legislation passed a law that required facilities to report deaths, not injuries, that were related to the use of restraints, those being physical, chemical, or environmental. Following the act of legislation, hospitals began reporting 2 or more deaths per month that were related to the use of restrictive measures. In 2010, the National Disabilities Rights Network reported that 39% of all states in the U.S. still have no laws, policies, or guidelines concerning the use of restraints or seclusion. 87.5% of states and territories in the U.S. still allow the use of prone restraints that restrict an individual's ability to breathe properly. 45% of the states and territories recommend or require schools to notify parents or guardians when restrictive measures are used. Over the past 2 years, there has been growing concern about seclusion and restraint use in school settings. This comes as a result of an increase in reports of mistreatment and deaths of children when they are subjected to restraint use throughout the nation. The third point I would like to address are the psychological, physical, and emotional consequences of restrictive measure usage on both clients and staff members. In an article written by J. Marino-Cody in 2013, both staff and individuals reported physical and psychological symptoms following the use of a restrictive measure. Individuals often experience nightmares, intrusive thoughts, and avoidance responses resulting from their experiences with restrictive measures, as well as obvious startle responses associated with being restrained. Individuals may also feel physical pain, anxiety, psychological distress, and anger. Clients were asked by means of a survey about their feelings before, during, and after restrictive measures. Anger was the highest reported emotion prior to the physical intervention. During the physical intervention, users reported sadness, anger, fear, and fatigue. Following the use of physical restraints, the most reported emotion by clients was a feeling of shame. Only one user reported a feeling of happiness after the use of a restraint. Staff members reported having negative emotions such as anxiety, sadness, and guilt that encompassed all restrictive measures. The fourth point I would like to address is the effect of staff burnout, not only on the staff members, but the effect on the clients as well. It is characterized by emotional exhaustion, a reduced sense of personal accomplishment, and a depersonalization of the client. There are many factors that can lead to staff burnout. Some of the highest reported factors are high levels of stress, lack of communication between staff, lack of support from administration, service user characteristics, challenging or violent client behavior, and poor coping skills. Staff burnout, it is not only the staff members who suffer, the clients do as well. Staff may become counter-aggressive with the individuals, or they may stop paying attention to the clients entirely. This results in neglect or harm coming to the client because of a lack of supervision. Staff may even turn to illegal substances or excessive alcohol use in an attempt to cope after a difficult day at work. Administration and staff members can help reduce staff burnout by having team building exercises, trainings, and show their staff their appreciation. The simplest ways for administration to assist with the reduction of staff burnout is rotating their staff throughout different environments so staff members do not work with the same challenging client on a daily basis. They can also encourage the use of breaks and mental health days. The final point I would like to address are the adverse effects of restrictive measures. As you can see on the slides provided, the top 7 causes of injury and death with the use of restrictive measures. In the years of 1988 and 1998, there were a total of 142 reported deaths in mental health settings that were connected to the use of restrictive measures. An inordinate number of these deaths were young children. 1998, the Joint Commission Accreditation of Healthcare Organizations, or JCAHO, reviewed a total of 20 restraint-related deaths and found that 40% of them were the result of asphyxiation. The remaining 60% of the deaths reported were caused by strangulation, cardiac arrest, and fire. Reported that staff members placed an excessive amount of their body weight on the individual's back while they were in the prone position and used towels and sheets over the individual's face to protect staff from spitting and biting. Written by J. Marina Cody in 2013, it was reported that there were 45 child and adolescent deaths associated with restrictive measures. This article also reported the death of 38 grown adult men. 7 of these men died from the use of mechanical restraints. Others reviewed 63 cases of death caused by asphyxia. The ages of the individuals ranged from 26 weeks to 98 years old. Restraints were reported as being performed properly in 57 out of the 63 cases. Despite having the proper training to implement a restrictive measure, there is still inherent danger to both the client and staff members for injury and death. What has been discussed, restrictive measures are only to be used at a very last resort when the individual is engaging in significant harm to themselves or others. That being said, restraints should not be utilized by untrained staff members and requires much oversight and control by the clinical team. The use of restrictive procedures is not regulated in all states and territories in the U.S. and must become regulated to safely implement these interventions. Restraints are traumatic to not only the individual, but staff members as well. They cause physical and emotional pain to all involved, exhausted, and become counter-aggressive to clients as a result. Restrictive measures are dangerous even with the proper training. Thank you. I will now send it to Casey for a review of the current research on the use of restrictive measures.
Thanks, Abby. As we just heard, Abby discussed the cons of using physical restraints. Just as Michaela had done, Abby had also used peer-reviewed articles to support her stance on this topic. Some articles used were written by Vollmer, Wessling, Howard, and Viliana. Vollmer had expressed that it is important for the use of least restrictive environments, while also noting the importance of informed consent, oversight, and monitoring. Restraints are used to help reduce self-harm and dangerous behaviors to others, although it has been hypothesized that the use of the restraints have negative impact on the relationship between the client and the professional. Wessling, Trader, Smith, and Marshall, of the article of 2010, produced a study to see how the restraints were perceived by both professionals and clients. After the intervention was completed, it was reported those involved with the restraints, both clients and professionals, do indeed experience negative emotions when the restrictive method is implemented. Finally, another important topic Abby had touched on was the effects of being burnt out. With burnout, it may result to lower quality service given by the staff. Howard, Rose, and Levinson of the 2009 study conducted was determined that if there is a higher levels of violence associated with higher levels of fear of violence and burnout. Specifically, does the lack of staff report and self-efficiency affect burnout, or does the moderate staff support and self-efficiency help the relationship between violence and burnout? After surveying a total of 83 care staff, it was determined that burnout was correlated with staff support. In conclusion, it was determined that the hypothesis was supported. Fear will be reduced in staff for those who are exposed to violence often. Overall, there are multiple cons that are addressed in the reason why physical restraints should not be used with clients. Next, I will pass it over to Rachel, where she will be discussing the final thoughts and questions.
Thanks, Casey. Our professor asked us, you mentioned staff burnout due to violence in the workplace. In order to keep the staff without compromising the client's needs, are there any strategies or methods that you can help improve training for administering restraints and or for the need for restraint? Caitlin will be answering.
I think it's important to be able to observe the triggers that might occur before behavior escalates. We can always be better at implementing antecedent interventions, which is a really important part of what we do on a daily basis. Also, the more education from a behavior analyst and in-person training can also provide help to improve overall training and handling of behavior, especially according to that behavior support plan that's been put into place. I also believe that the more comfortable a therapist is in implementing the support plan, the better support can be given without having to use a restraint. If a restraint is absolutely needed, ongoing training should be provided with the competency checks. And I also think that a code should be called if there is a restraint that is needed to be used, just to provide that support and also to have a witness to back up any questions or concerns from parents that could arise after the situation of being restrained did occur.
Our second question that the professor asked was regarding the 3 types of restraint: environmental, physical, and chemical. Which restraint, if used appropriately, are typically the safest and bring about positive results in the least intrusive manner? Abby and Michaela will be answering.
Thank you, Rachel. Each of these types of restraints are considered invasive. In my personal experience, the most traumatic responses I have seen have been from the use of chemical restraints. The person is aware of everything going on around them, but has little to no control over their body. Chemical restraints also require accurate measurement of the substance. If given too little, it has no effect. If given too much, the result can be drastic. With physical restraints, the staff is implementing a restrictive measure that may cause harm to the individual, but if implemented appropriately, it does not always result negatively. Individuals can understand why the physical restraint was used. They are able to debrief with staff following and can speak about their feelings. Environmental restraints, or seclusion, removes all stimuli from the individual in hopes of calming the individual. Seclusion may teach the individual to self-soothe, but is it an ethical practice? My experience with seclusion is that it is not the least restrictive practice. It separates the individual from their peers and may even cause shame. It is also dependent on the type of room the individual is placed in when discussing the individual's safety. Whichever option must be chosen, seclusion may be the better practice, as it is less intrusive to the individual, seen simply as a timeout.
Thank you, Abby. I believe that environmental restraints are the safest and bring about the most positive results. If the child can be safely monitored from outside the room and they do not have the potential to engage in serious self-harm, this is more than likely the best restraint to use, as there are no hands or chemicals being put onto the client. I also agree with Abby that chemical restraints are the most traumatic for a client, although I have never seen any of them in person. But I can only imagine how terrible it would be to not have control over your own body.
Thank you, Abby and Michaela. Our third question that the professor asked is, have any of you discussed restraints with other professionals, been trained to use restraints, or heard about the inappropriate or appropriate use of restraints in your past or current work environments? Rachel-Mae will be answering.
Thank you, Rachel. Many of us in our debate group are trained in various restraint procedures. There's one individual that is trained in safe crisis management. There is another that is trained in CALM, which was put into place by the New England Center for Children. There are a few instances of restraints being used inappropriately in workplaces that our group members have observed or talked to others about. Often they have noticed that staff members become burnt out and act in a counter-aggressive manner. They feel that their staff members feel that the restraints are used to put the individual in their place, not for staff or the client safety. That it's more of a control factor versus an assisting factor. They have staff members, we've had people in our group that have staff members that focus on reducing the number of restraints used monthly. There also have had staff members who provide supervision in an appropriate use of restraints. We even have a group member who their workplace retraining requirements are for every 6 months, And if a staff member uses a restraint inappropriately, they are removed from the service and must go through training again. I am in a unique situation because my profession is more towards geared towards education versus special education or ABA. In my situation, I work in early child care center in the state of Indiana. In the state of Indiana, early childhood centers that are licensed have to follow licensing guidelines set through the state. So that is one area where the state of Indiana has set guidelines for centers, quite a few, and Restraints is in one of those guidelines. It is a licensing regulation for early education centers, and you can receive a violation if a restraint occurs. The definition of restraint can even be down to putting a child into timeout. So in the state of Indiana, if someone is walking through your school and there's a teacher who, because of a child having a tantrum or not listening during circle time, and a teacher has a designated timeout area, if a parent is walking through the hall, if another teacher observes the situation, then they can report it directly to the state. If this is reported even anonymously to the state is required to follow up. They come in, they interview the directors of the center, they interview the teachers, and all the information that they find, even if they don't have any physical evidence or don't know if something happened or didn't happen, everything gets put on your permanent record. So in the state of Indiana, you are able to look up licensing violations for every early education center that is licensed. And that will say on there, down to leaving the water running too long or not washing their hands. It will also say if they observed a teacher yelling at a child or a restraint in the form of timeout as well. So that is one way that restraints look a little bit different in a different profession. I'll hand it back over to Rachel.
Thank you, Rachel. Another question that was brought up through our debate was, should the behaviors of a staff member performing the restraint be criminal? Casey will now be answering.
Thank you. As far as criminal, the reason why it would be criminal is if there was restraints that are used and there was no consent provided, it is considered a criminal act. Also, another form of criminal act would be if the restraint is performed inappropriately or cause significant harm to that client that the restraint is used on. Although if there was consent provided and the restraint was performed correctly, criminal harm should not be related. I'll pass it back to you, Rachel.
Thank you, Casey. I will now pass it back to Caitlin, who will now close out our debate.
All right, thank you guys for joining our debate, which discussed the pros and cons of using restraints and seclusions. We hope you learned some important information and insightful information today that you can use in your everyday work practices. Feel free to post questions to us that you may have in the discussion board for the week. Thanks again.